Cardiomyopathies are basically any abnormal myocardial structure or function that those settings, we have this then abnormal cardiac myocardial structure. So now we have this classification of primary cardiomyopathies versus secondary, where secondary is this kind of storage disorders or infiltrative disorders or consequences of other things, right? So maybe they had some cancer treatments or something like that that has caused cardiomyopathy, where primary is genetic and it includes some acquired as well. Okay, but it's just strictly to the heart, not a whole other disease process, right? So our hypertrophic cardiomyopathy is where we have this kind of thickened and stiff myocardium. And it is the most common genetic disorder, basically, has prevalence of 1 in 500. This is where we have patients who drop dead on the field sometimes, unfortunately. So HOCM is where that really impacts that scenario. So HOCM is hypertrophic obstructive cardiomyopathy. So we can have hypertrophic cardiomyopathy that doesn't obstruct the outflow from the ventricle. But with HOCM, it actually obstructs the outflow. We always want to think about what it does to our pressure, right? So our pressure gradients are key. When we have a hypertrophic cardiomyopathy, we have this dynamic. Remember, we talked about a dynamic waveform, but our dynamic waveform causes this, we have a dynamic pressure gradient. So that's why we get the dynamic waveform. Because it is dynamic, that tells us that it's not a fixed obstruction. It's not just at the valve. So it kind of changes throughout the cycle, right? So we get this kind of change happening here. So we talked a little bit about SAM, systolic anterior motion of the mitral valve, right? So there's, when we have hypertrophic cardiomyopathy, we see that septal thickening, we get that SAM going on. We have this dynamic waveform that is kind of late peaking, right? And so that's an indicator that there is a hypertrophic cardiomyopathy happening. So then our, it's a dynamic LVOT obstruction, right? We know that. We talked about this before. So this is that SAM that we talked about, that systolic anterior motion of the mitral valve, right? And so it's hitting that septum during systole when it should not be doing that, right? Normally in systole, the mitral valve is trying to stay closed to keep backflow, that MR from happening, going back into the left atrium, right? But then, with HOCM, with SAM, we get this, again, dynamic appearance to the waveform as that septum is very thickened and it blocks the outflow, right? So we get that suction of the anterior leaflet of the mitral valve into the septum during systole. So here we have that anterior leaflet of the valve, and it's getting sucked up against that septum in the same waveform. And this is a little bit of that breakdown there.